Hello, everyone. Welcome back to another episode of Everything is Public Health. I'm one of your co-hosts, Mr. Murray. We have our other co-host, Dr. Murray, and we have our super producer behind the scenes, Mr. Andre Moore. Today, we have two wonderful guests. We're going to be talking about the year in review. You don't know what we might be talking about or where it might go. So before I introduce the guests, I just want to say this. The vaccine is coming out. I've been hearing a lot of things about people's unwillingness to take it. I won't discuss that right now in this little part. But a lot of my peers, even some of my family members, have been complaining about wearing masks. You usually put on a mask when you're going out in public. The mask protects you from infecting other people. People have been saying, "Oh, I have asthma. I can't breathe. I can't wear a mask. I have allergies. I have a stuffy nose." Just to prove to everybody, today for this show, I'm gonna wear a mask. So if I faint, pass out, then you can't wear one. But if I could wear it, a brother that carries tissue everywhere, Kleenex everywhere he goes, then you can wear one as well. So let me introduce my guest. Please introduce yourself, Dr. Kiran. Let's start with you, brother.
Thank you. Hi, Marcus. Hi, I'm Kiran Joshi. I'm a medical officer and co-lead at the Cook County Department of Public Health. And I'm also an attending physician with the Department of Family Medicine at Stroger Hospital.
Brother Jose Ramon.
Hello, I'm Jose Ramon Fernandez-Pena. I'm the current president of the American Public Health Association. I'm also a physician, but I don't practice. I haven't practiced since I came to this country. And I work as director of the Office of Health Professions Advising at Northwestern University.
Excellent, excellent. Dr. Murray, start us off today.
Well, I think when we look back at what's going on this year, I'd like to start with a feeling. I was just thinking that I haven't hugged my grandchildren since March. You know, I go out maybe once every other week. So this has been a very, very, very difficult year for us. And I think the real question that we're facing as public health folks are some of the questions you raised, Marcus. Now that we have a vaccine, and let me start off with a general question then about this. Many people feel like, oh, we have a vaccine, everything's over. We don't have to wear a mask anymore. We don't have to do anything. You know, we can go back to party. So I just want to make a note and ask, especially Jose Ramon, perhaps to give us some wisdom on this. It's been 40 years since the HIV epidemic has ravaged the world. And even though we now are in a position where HIV infection and AIDS can be a chronic disease, people no longer have to die from it. In fact, if you are appropriately medicated and we control the viral level, you don't even have to transmit it any longer. But still, infection rates are going up in certain communities, especially communities of color. Not only around the world, but especially here. So everybody in the world that could benefit from these medications are unable to take them. What kind of lessons do you think that we can learn, Jose Ramon, when looking back on this 40-year global pandemic as we contemplate what might be happening in the next year or 2 or 5 with COVID-19?
I think there's so many parallels to draw from the two pandemics. And certainly for me, I was a young and eager health educator volunteer 40 years ago trying to do something about how HIV was ravaging my Latino gay community. So when we started seeing the beginning of this epidemic, I had numerous flashbacks to those early days of anguish and fear and what can we do and when do we do it? And the early development of medications, they're going to kill us. The medications have not been tested with people of color. They've only been tested with white folks. They're gonna use us as little rabbits in a lab. I can draw many parallels to what you're doing right now, Marcus. You're wearing a mask, and I can remember having many conversations about wearing a condom. Nobody wanted to wear a condom. We knew that condoms were effective, that they helped, and nobody liked them. I didn't like them. I can hear the conversations about this was a secret disease developed in a lab in order to get rid of all the drug users and all the gay folks and all the people of color that were falling prey to this. There's so many parallels. It's just mind-boggling, and I am I'm sorry to say that I don't think it looks like we learned any major lessons or that we are applying any of the learnings that we developed in those days. It was very telling the other day, the first shots of the vaccines. I was writing about this. It was the symbolism of having an African American physician give the first vaccine to an African American nurse. The symbolism of that was not lost on me. It was like watching Elvis get vaccinated on TV for polio in 1956. So I think that some of the lessons we can probably draw from is the fact that in order to convey a message effectively to a community at risk, it's essential that we have folks from those communities be the ones that deliver the message. The relevance of cultural linguistic competency of the messengers needs to be forefront and paramount. I think we also need to talk to communities the way communities talk. We have had every doctor and every scientist on TV talking about this ribosomal RNA delivery method that codes appropriately through the process despite nobody understands that. We need somebody that can say, this is a vaccine that you take it twice, and it's very likely it's going to help you. And yes, right now, we don't know what are going to be the side effects a year from now. We know that today, what we know with the data that we have, that it's safe for you to take it. So I think we need to take a step back and be careful and intentional in customizing messages for communities at risk, which is today's every community essentially, in a way they can understand it. I've been working at Northwestern with a particular group of students to try to develop messaging that uses the platforms, the languages, and the spaces that they hang out on. In my day, we did T-shirts and we did, other things. Today, we do posts on Instagram. And I'm not going to be the one posting anything on Instagram because nobody's going to follow me. But my football captain person can convey in an image, in a word, something, and followers would be perhaps early adopters if we think about the frameworks of public health theory. So the diffusion of innovation happens perhaps when you have those role models. When you have Michael Jordan wearing Nikes, everybody wants to wear Nikes. So when you have somebody like the good student or the popular student be modeling the behavior that we desire in terms of wearing masks, maintaining distances, washing hands, it is easier and more palatable and more, I think it's more effective means of transmitting information. So some of the things that come to mind.
Let me interject right quick before Dr. Kiran jumps on, because I agree with Jose Ramon about having culturally specific messages. Like that's a Taylor Project Brotherhood. That's what we do. We just make all our messages to reach the people. But you spoke about the symbolism of the two black women giving each other the shot. There was issues with that in my community. My community saw that as kind of offensive, because there's still a mistrust for the medical community. So what I want to throw in is when we talk about customizing messages, it also depends on who's customizing them and who's putting them out. Because I'm sure the news media didn't ask, any black person, hey, what do you think about these two women? Right. So we have to be careful, but jump in, Dr. Kiran, jump right in.
Yeah, I mean, so just a couple of things, when you just said that, Mr. Murray, what I was thinking is it's about power, right? Like who has the power and like, where is that message coming from? So I was just struck by that. And so anyway, that's just like my brief observation. I was struck by what you said, Jose, just now, just in terms of the parallels with the HIV pandemic and, the human cost, right, of this, where like I came of age in like the 80s and 90s, and, ARVs were like really peaked like around 95, and then mortality started to decline. So I didn't experience the worst of the epidemic. I did my training in preventive medicine at Hopkins, and I spoke to this guy, Chris Byrer, who's a great guy, HIV researcher. And, he and I kind of talked about what it was like for him as a young gay man growing up in New York. And the one thing he said to me, which has just stayed with me always, is essentially that everyone he knew died, and it just like blew my mind. Like, how could that have happened? And, now, of course, it's a very different demographic that's been most impacted, but we're seeing some of the same patterns play out, right, in terms of stigmatization and some of the issues that you described around prevention, right? I think what's most troubling that I read most recently is the way that we're seeing higher income countries pretty much engage in hoarding, right? So there was a story recently talking about how Canada had bought up like a really ridiculous supply of vaccine far above and beyond what their population might require. Well, what's that going to mean for the low middle income countries around the world? I mean, it's really troubling.
And if I may just say, I can show you my little phone book. We had phone books at the time, and you enter people's names on it. Linda is laughing because she might remember this too. So I can show you my phone books for those days with the names crossed out.
Yeah.
And also of note is today, I believe there are documented something like 76 million cases of HIV, and about half of those have died and half of those are alive. In 40 years, we've been dealing with this sucker now for 10 months, and we have 76 million cases. Mm-hmm. So clearly the mortality is not the same.
Yeah.
But the same federal neglect of a pandemic emerging.
Yep.
And the same, and this is Kamara Jones's line, the medicalization of a public health problem is exactly the same. We went for treatment, we went for vaccines. HIV, we're still looking for the vaccine. And we neglected prevention. And this is what we have been doing now.
Yeah.
So I think one of the things you mentioned, Marcus, becomes critical. And certainly, while I think it was a good visual to have a Black physician give the shot to a Black healthcare worker, we have a special responsibility. So let me I'll tell you a story about my parents, both of whom are deceased now. But as they aged and they were navigating the medical care system, they had a daughter that was a doctor. So I was trying to help translate, this means this, and this test you ought to get. Now, they did always get their flu shots. Let me just say that. But I was trying to explain something to them, and I don't even remember what it was. And they stopped and looked at me, and they said, Linda, we don't trust doctors in the healthcare system. And we haven't forgotten that you're one of them, their firstborn child. So now they loved me and they clearly trusted me, but that's something as health professionals of color we have to remember. So if we step to our communities the way the white folks step to our communities, they're going to ignore us. If we step there, I'm the doctor, I know what's good, just do this, don't ask no questions, you'll be okay. That's not adequate enough on a new virus with a new vaccine. Yeah. And not only that, we have several different kinds of vaccines, and we have several different classes of vaccines using different technologies, which makes it even more confusing. I think a number of those will end up being approved also. So we really have an obligation first to educate ourselves. I'm not a vaccine person. I'm not an infection. I'm a general internist and a specialist in environmental health. So I have to put in some extra work to be clear in my mind what's going on. But we have to be willing to talk to people, not only in plain language, but we have to be willing to admit what we collectively don't know. Yep. So there's so many that, as soon as it's my turn to take the vaccine, I'm going to be in line to take the vaccine because I would like to get out of quarantine. I would like to get out of my house and see my friends again. But But if we're not willing to talk about what we don't know and what we can't know what the side effects are going to be 5 years from now. People have only had the vaccine for 2 months. So if there's a side effect 5 years down the road, we're not going to know about it.
Yeah.
So if we're not willing to do that and to speak to people with respect, because when people have questions, they're not dumb questions. It's very interesting when you look at the surveys that have come out. Lots of white people, for example, one of the major reasons that white people don't want to take the vaccine, not the only reason, is because many of them, I guess they're Trump followers, they don't believe COVID-19 is an issue. So I don't have to take the vaccine because I don't believe in it. Whereas, we're seeing people, more than half the Black people in these surveys and even a higher number of Latinos in these surveys know someone that's died from COVID-19. Okay. And so we have a different perspective. So we really have to step to our community with respect and some appreciation that this is not obvious to people and be able to have a dialogue, because I do want our people to take the vaccine because we're dying at such higher rates.
Right.
So what about the idea and concept of herd immunity? Like some people are saying, I'm not going to take the vaccine. I'm gonna let the people who take vaccines take it, and then herd immunity will kick in. What are you guys' thoughts to that?
I mean, that's a great question. So first, I don't think we're clear on what the level of herd immunity is. And we're not clear. So let me just say one more thing, which goes to Linda's previous point about the uncertainty, right? So the way the vaccine trials were done, we don't know if people can still continue to acquire and transmit asymptomatically, right? So that's a huge uncertainty, right? Because it could still continue to impact people even after there's high levels of vaccine uptake. So I think that'd be actually one argument towards getting the vaccine and maybe not so much relying on herd immunity. It's hard to combat that a little bit because I sort of feel like, there's a logic there. Like I could sort of see that. But at the same time, it's like this whole thing, our society, public health, and like our public health interventions for this pandemic are like an exercise in altruism, right? That's why Linda's been hanging out in that same room for months, partially, right? She wants to protect herself, but I'm sure she wants to protect others too. So to some extent, we have to rely on others to get vaccinated for us to all protect one another.
Right, and I think it's again important. The message is important, and perhaps even more now because, in my mind, these vaccines are what the antiretroviral cocktail did in 1995. It was the opportunity to drop the condom, and people are looking for the opportunity to drop the mask. And people want to hug, and people want to be together because we're social animals. It's our normal behavior. So now we're saying, here's the vaccine, but yeah, take the vaccine and keep the mask on and stay home.
Right.
And I said,
Right. So
what you telling me?
Right. So why do it? Why should people take that chance?
Well, here's the reason.
On a drug this new, when it usually takes 4 to 5 years to come to market. Then we're talking about giving us something that they developed in less than 6-9 months.
Well, here's some reality that we have to talk to. First of all, it just looks like it developed in 9. That's like when Michael Jackson breaks out and or name I can't. So you see how old I am. I can't think of a modern. But anyway,
Taylor Swift. Taylor Swift. I like Taylor Swift. Her album just dropped.
Okay.
You ain't know a black dude like Taylor Swift.
No. In any case, somebody makes it big on the scene, and it's like, oh wow, they just popped out of nowhere. When really they've been working for decades, just not hitting it big. That's how it is. So we need to be clear. Like I do think
so working on what? So, a form of SARS? Is that like
no?
Be more specific.
Well, I'm gonna try and be specific. So
they knew this existed, or what do you mean working?
So first of all, some of the underlying technology, if we just concentrate, because I don't have time to talk about all the vaccines. The two vaccines that are about to get, the Pfizer and the Moderna, which is going to be, I guess, approved this week. Both of those are resting on this RNA technology. That technology didn't get developed in 10 months. That technology took a long time. We invest money, millions, billions of dollars in building the infrastructure that allows us to suddenly make a vaccine. So the technology about mRNA and how it works and all that kind of stuff, that took decades to develop. And during the SARS epidemic, which is more than 10 years ago now, they actually started working on a vaccine, but the epidemic stopped. And so in typical stupid fashion, they stopped working on it. So when this happened, this is basically a cousin of SARS. It's in the same family. They resurrected all that work. So even though it is amazing that they worked together around the world and did it in 10 months, but the reality is they were building on several decades of scientific research. So that's the first issue. The second issue that I'm going to be real with people, because, it's easy to think. That's like saying the average salary in the United States, I don't even know what the average is. If you were with me and my friends and Bill Gates walked into the room, our average money would be huge because he's a billionaire. But that doesn't really tell you how much money I have or how much money somebody else has in the room. So we should remember what herd immunity means. We don't know the percent we have to be at. It may be up as 90%. That means over a big population like the United States that the virus won't spread quickly like it is now, where you have ICUs filling up. Don't forget, our immunization rate for measles is pretty high, but we still have outbreaks of measles. So what's really important is what's going on in your neighborhood. So if you live in South Shore and everybody there is I'm going to wait till herd immunity kicks in, the immunity in South Shore is not going to be anywhere close to what it might be over the whole city. So what you really need to be worried about is how many people where I am are getting vaccinated? How many people in my family are getting vaccinated? Because there will still be people that get coronavirus when the herd immunity is functioning. It doesn't mean nobody gets it. And so I'm just going to ask a typical Black person, who do you think is going to be likely to be getting it? People that couldn't afford the vaccine or for whatever other reason didn't have access to the vaccine. So this is not a guarantee of anything, but I don't know the numbers for everybody. Obviously, we know younger people don't die as frequently as older people, but I happen to know from my age, I'm 72. If I get the coronavirus, my chance of dying from it is like about 1 in 20. Okay. Now for younger people, it's much, it's like 1 in, a couple hundred or maybe even a couple thousand. But for me, as 72-year-old, if I get corona, I have a 1 in 20 chance of dying. So I'm not willing to take that chance. That's why when my turn comes, I'm going to get the vaccine. And people should ask themselves, well, what's the chance that my mother might, if she gets it from me, what's the chance that she might die, or my grandmother, etc. So when you look at it that way, even though herd immunity is an important public health concept, from a personal point of view, you have to understand that some vulnerable communities, because of where we live, where we work, how much money we have, will still be at higher risk for getting this virus and dying. And that's why I want people of color, essential workers, I want them to get in line first.
Well, so let me ask this. Well, I'm going to say a statement before I ask the question to the panel. I'm not necessarily going to be encouraging people to get the vaccine. I want to educate them first and let them make their own decision, because it's hard for me to tell them, we haven't come up with a cure for the flu, cancer, now take this vaccine that they just came out with. You can still be asymptomatic, blah, 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 blah. So let me ask you all this. In terms of being mandated to take the vaccine, is there any talk in the state of Illinois that you all heard of about trying to mandate for certain places like hospital workers, universities, schools? Is there any talk of that in the political arena and in the public health arena? Because there's also a concern about people being mandated to take the vaccination.
I am going to defer to the state people here. I'll tell you from when I used to work at Bellevue Hospital in New York or at Mission Neighborhood Health Center in San Francisco as an employee, I had to take a tetanus shot, and I had to be tested for tuberculosis, and I forget what else I had to, my MMR. I had to have the MMR shot. Those were conditions of employment.
I think employers are allowed to mandate, but there are different kinds of mandates, right? Because there's employer mandates, and then like there's vaccines that we sort of quote unquote mandate for schools, right? So it is possible, but it's like in this instance, would you mandate it as a public health policy for a new vaccine that has been shown to be safe, has a good safety profile, but as per the first part of this conversation, wanting to be real with everyone, has only been studied essentially for 2 months, right? I don't think I could do that. I don't think I could support that.
And actually, you have the authority to actually assist with that as a public health official if you wanted, like if the state wanted to, right? Or the county.
Linda's smirking because she's like, he doesn't.
Well, actually, yes, the answer is yes. You legally could do it, but the question is, should you do it? And so I would argue we don't know enough about it. So, and I want to make a distinction here. My understanding, having been on some meetings where this has been discussed, is that employers of any type can mandate a whole bunch of weird stuff as a condition of employment, because their position is, well, if you don't want to do this, then you can't work here. And in general, I think you have to be, to me, there has to be a good reason for doing this. So in healthcare, which is where I've historically worked, I don't want somebody who can get measles and pass it on to a patient, say a baby that's too young to get measles shots yet. I don't want that person working in my nursery where they can infect babies just because they themselves don't want to get immunized against measles, a perfectly long-standing safe vaccine. The same thing with flu. Again, elderly people that get flu are much more likely to die, even though most of people that get flu recover fine. So the logic behind having, especially healthcare workers or other people, school teachers who are in a position to infect people, to say, no, if you're going to work in this sensitive area, we need you to have these protections. I agree with that in general. For COVID-19, we're not there yet. We don't know enough about this disease, and we don't know enough about the vaccine. So we don't even know if you get the vaccine. We don't know if you're safe from spreading it, like we talked about before. Yeah. So maybe in 10 years, I might agree to mandate COVID vaccine. But today, and for the foreseeable future, I don't think that's the way to go. I think you have to pay attention to people's fear. That's a very real thing. This is a brand new virus, and it's a brand new vaccine. And you don't want to create more problems by mandating something that you don't have a good reason. It's not clear it's going to solve any of your problems.
Yeah, I would worry about the backlash to any kind of mandate for sure.
Mr. Murray, may I go back to something you said about you're not going to be advocating one way or another about the vaccine? And I completely agree with that stand, and I would do the same. What I do think we have an obligation to do is to provide correct information to dismiss the theories out there. So we have an obligation to deal with misinformation.
Yes, I agree with that. I agree we have an obligation to educate. But then again, from my perspective, from a Black man's perspective, it's hard to convince my people when we have a long history of being, having experiments done, that mistrust for the medical community all, in general. It's hard for me to say, go in there and get vaccinated. It's not going to keep you safe. I don't know anything about it, but I can educate you and tell you what's in it, what to expect, where to go, how much it costs, if it's free. Well, actually, I do have a question. Will people who don't have insurance have access to the vaccine?
Yeah, so the federal government has paid for just a massive number of vaccines. So the vaccine itself is going to be free. Healthcare providers can charge an administrative fee and bill that to an insurer or Medicaid or Medicare For uninsured people, there's a mechanism through which they can seek reimbursement from the federal government. But that's part of the CARES Act legislation, and that needs to be renewed. And I'm hopeful that they're gonna do that with this new round of COVID relief that they're looking to pass right now.
So that's why the devil's in the details, and we have to really stay on top of this. For example, care. If you were hospitalized in April or May, in theory, you were supposed to get no charges from that because of the CARES Act and other things. But in fact, we had experience out of the county system and around the city where people would be discharged. Yeah. They would come in, they would have no insurance. They were able to survive. They would be discharged, and many of them would need home oxygen. Well, home oxygen wasn't part of the deal. So you had people who needed oxygen at their home, and that's a couple $100 a month. And so people had to scramble to try to find some way to support that. The same thing here. Yeah, the vaccine will be free, but the people who give you the shot have to get paid. And so we have to really make sure that it's actually free and accessible to people so that if they choose to get the vaccine, they can get it.
We've seen the same issues with testing, people wanting to charge this sort of like administrative fee or doing like a bunch of other tests that they may or may not need along with the COVID test. So,
and children under 16 are supposed to be vaccinated, right? Or is it under 12? What's the deal with that?
It was 16. So the trial, the Pfizer trial was 16 years of age and older. So, okay. Yeah, I think they're going to do more studies, now that they've established the safety profile to include children.
But now, correct me if I'm wrong, Kiran, wasn't the Pfizer just approved right now for 18 and up? Or was it they weren't unanimous at 16? Was it approved for 16 and up? There was some dissent about the 16.
So if there was something in the FDA emergency use authorization, there may well have been. My understanding is that it was 16 and up from reading.
Well, actually, now that you say that, you're right. It was 16. But what happened was the committee, the FDA committee, there were several members of the committee who didn't want to approve the 16 to 18 years.
Yeah, I noticed that. There were like a couple of people who were like, I remember because when I read the vote, it wasn't unanimous, and I was puzzled by why. So yeah, that
so that's important to understand too, because it's out in the press and people don't. So the problem wasn't that there were problems in 16-year-olds. The problem was they didn't feel there were enough 16-year-olds in the study for them to make a judgment. That was the reason why they didn't vote for it. And it's exactly these kind of details that cause people to pause and be worried about what's really going on. And understanding how younger people will be rolled into the vaccination, because there are plans to do that, which is not unusual, but again, that's hard for people to understand, and it needs to be explained more clearly.
Yeah.
So Marcus, what kind of things are people saying? What do you hear out in the street?
I was about to ask that.
I'm sorry, I didn't hear you.
What kinds of things are people saying in the street in terms of why they don't want to take the vaccine?
What they're saying, they don't trust the government. We talked about medical mistrust, just the short term in terms of how quick the vaccine was from, production to shelf. And just that whole thing, there isn't a cure for HIV, there isn't a cure for cancer, there isn't a cure for the flu. We get the flu shot every year. Why would we take it? There's just that lack of trust and information. And a lot of it has to deal with the last president. Just the past 4 years coming from the White House, people don't trust anything the government has said. So,
well, that's
and then the people,
understandable.
but here's the thing. The individuals that I'm talking about them are usually older, and take the flu shot. Their concern is they won't have access to it like they didn't have access to COVID testing for months. So there's also that fear of the South Side and West Side of Chicago where Black folks live being left out, even for the ones that want to be vaccinated. So, we're always the last ones.
So I'm just curious, you're a younger than us, at least, not younger than Kiran, but younger than me and Jose Ramon, a public health professional. What kind of things should we be doing as a public health community in terms of addressing these issues?
I mean, it's the same thing we do with every public health problem. We have to meet the people where they are and talk to them and involve them in it. You know, for public health, we all like to use community-based participatory research. We have to go in the hood and say, hey, what do you think about COVID? What do you think about vaccinations? How can we start talking to you? Like, what are these messages cool? And then what else do you need? You know, we can't just come in there and dictate to them. Let's see what else they need and try to leverage some of those resources to them. It's hard going to come in the hood to a family who might have, if one person lost their job, if they already suffer from some other chronic issues and aren't at home, like people's lives are disrupted right now. So the last thing me as for the sake of this show, a public health professional wants to come in and say, hey, get vaccinated. This is the American way. Do your part. Man, you know, that shit won't work. So we have to figure out a way to communicate better with all communities. You know, I'm speaking for the Black community, but whatever community you're in, your neighborhood, your population, you have to figure out a way to just communicate with them. What do you all think? What do you think, Jose Ramon? Because we discussed the similarities with HIV/AIDS. Is it having more peer educators out there educating folks?
I completely agree with your point, what you're saying. I mean, and I think that in general, the public health sphere and space understands and in most cases tries to work by the methods that you're talking about, community-based participatory research, understanding that it's not a matter of coming in, going out, building assets, identifying what are the needs, not as an observer, as an intruder into a community. So those approaches, I think, are tried and true, and there's, you know, extensive literature and extensive evidence that those are well developed and thought through interventions that actually make a difference, as opposed to let me come and tell you this is your problem and this is how you're going to fix it. So clearly and in the Latino community, which is the one I'm more familiar with, the fears and the concerns that you're citing are just as prevalent, also related, not in a small part, to the rhetoric that the administration has used over the past 4 years regarding immigrant communities. And we will not get into that space, and I think that for the little I know, in the Native American communities, we have even higher mortality rates and fewer opportunities to access services. So the decimation in those communities has been also quite dramatic. In addition, we do not have a good enough representation of communities like ours in the health workforce in general. So when it comes to the point of trying to work within as an insider, it's very difficult if I'm going to go with this face into that community and say, hey, I get you. I don't need to get a message from a Latino doctor, but in some cases, I may be more comforted when that message comes in Spanish, or when that message comes from somebody that eats at a restaurant I usually eat, or from somebody that says, oh, I got that same T-shirt when I was whatever. I don't know what it is, but you know, those commonalities that make you similar at a more human level, rather than I'm the one that knows and you're the one that doesn't know.
Makes sense. And then we have to think about COVID fatigue too, Doc. A lot of people are just COVID fatigue, and the fact that they, you know, COVID is not something. If you wake up in the morning, I have COVID, and you walking with a limp, you don't have signs like a stroke. So a lot of times these people, this younger group between, you know, 18 and 35, if you see them on social media, they're still at clubs and bars, and people aren't passing out and falling out around them. I'm sure they don't know the 500 people they're in the club with, but you see that and you think, okay, maybe I'm immune, not understanding what asymptomatic means. And other people see it and it kind of cables them up. Yeah, sometimes I get cabled up if I go to the store and I see people in the park like, man, I'm tired. I want to go out there. Let's just Let's hang out and watch the game together. Let me take that chance. I haven't hugged my mother since March. Let me go over there and hug her. But then I think, oh man, I can't take that chance and play with my life and people's lives like that. So education is key, I think. I think communities, black people in all communities, regardless of your income, they still don't have an understanding for COVID in general. So I still think we need to discuss, not on this show, but just discuss the impact of COVID, how it's transmitted. I don't think people understand asymptomatic, and just educate them more about that, and then let them make the choice on whether or not they want to get vaccinated. But I think as a country, we dropped the ball on educating people about the disease.
For sure.
I think the other issue, we said we were going to try and look back on the years. Let me just say, more shit happened to people than just COVID. Now some of it may have been related to COVID, but people lost their jobs. Millions of people lost their jobs and haven't gotten it back yet. What kind of disruption does that do to families? We had a sort of eviction moratorium. It didn't work that well. People still got evicted, but it's going to end at the end of this month, that eviction moratorium. And so we will have an increase in homelessness. The schools are a complete mess, whether they're college students or whether they're K through 12 students, and all of this ripples. So again, with the undergraduates that I work with at UIC, University of Illinois, that's a working class school. Many of those students work anyway, but suppose they're living in a situation, and most of them don't live on campus. Suppose they're living in a situation and some of the other adults in the house get laid off. That means they may have to pick up more hours. Right. If people are still able to, maybe the financial situation hasn't changed. I have students who, they're at home trying to do their remote learning, but they got, 3 or 4 or 5 nieces and nephews or younger siblings that they're trying to keep an eye on for the remote education of those kids. So there's a ripple effect that impacts everybody. And COVID-19, in that constellation of things that are bothering you, whether you have food, whether you can pay rent, whether you're going to get fired from your job, that's just another added problem.
But this brings me back. I'm sorry, Linda. This is not unlike the peak of the AIDS epidemic. So people had AIDS, but they were also homeless, and they were also had a drug addiction, or they were also had been evicted, and it was the cherry on top of the very disgusting pie of poop they had been handed. Mm-hmm. So how do you prioritize this when you say fatigue? I'm exhausted. So I don't know a person that is not fatigued of HIV. So it's...
Go ahead. So we had a quick question. And just to remind you, Doc, we did lose, Kobe Bryant this year too. Everything ain't public health. I know y'all a little old, but the year started off bad by losing Kobe.
Well, I would argue with you the lack of helicopter safety is public health issue. Which is one of the
I know that is. That helicopter was messed up. They didn't have the mountain sensor or something. We had a question, and people were asking, this current administration after the election, how do you think they'll handle the virus with Biden and Kamala Harris?
Yeah. When I first started at the health department, I remember talking to Linda about CDC and how to think about the recommendations that CDC makes. And at the time, Ebola was really just raging in West Africa. And we saw that gentleman pass away in Texas, right? And what was interesting is that the recommendations for PPE that CDC was making were very, very different than what we were seeing in West Africa. So if you compared a picture of what they were wearing in West Africa to what they were wearing in Texas, totally different, right? And in West Africa, it was more. And so I remember being a little puzzled by that and talking with Linda, and she was like, you always have to question, you always have to be critical. And so when COVID really started and we were seeing some of the recommendations come out from CDC, I kept that in mind. And there were clearly like particular recommendations and the timing of certain announcements that like you just had to question, you know? And I questioned those in a way that like, I don't think I necessarily questioned that PPE recommendation. You know, I think that recommendation was just kind of misguided. But here, clearly, like the level of alarm and the timing of the way certain things were expressed and the way they weren't recommending testing at certain times really just seemed to be so wrong to me, right? And it came out afterwards that there was direct political interference in those decision-making processes. So what kind of difference is it going to make? I think it's going to make a huge difference, because while I'm still going to be critical, I'm not going to be sitting here like, you know, trying to play a mind game with myself to think about who might have interfered and why, you know?
Excellent.
Yeah,
Well,
I think it's encouraging to see that there seem to be indications that the incoming administration would be interested in hearing what science has to say and would be basing, hopefully, policy decisions on evidence, not on you know, esoteric theories or ulterior political gains or processes or things like that. So, like Kiran, I'm optimistic, I'm hopeful, and I'm ready to be as critical as I can if I think it's important, or if I'm hearing or learning about what's not happening that could be happening or should be happening.
I think the issue we have here is that, so I want to say that we can quibble how many deaths can be placed at President Trump's feet. I think some deaths are his responsibility, but the fundamental problem in the United States is, first, we don't have a good public health infrastructure. We've defunded our public health system. So when I first entered the field, every state had a state lab. Okay, we've lost our public health labs. We've lost the ability. We've been laying off public health workers of all types, but we've lost the ability to quickly move during disasters. We've just defunded that into the world. Secondly, unlike Western Europe, for example, we don't have universal medical care. How is that possible for one of the richest countries in the world to have a health system where on every day you have millions and millions of people without medical insurance that don't have access to high quality medical care? We're seeing the impact of that now. Yeah. So there are 3,000 counties in our country, and half of them don't even have an ICU bed, not even one. So we have a lot of technology concentrated in a few big cities, but in general, we don't have the resources we need where we need them. And I think we'll see this as we try to immunize people. Third, I have a niece that's in Germany. When Germany in the spring were faced with this, they told people to stay home, and those workers got 90% of their income. 90%. Yeah. So we don't have the normal supports for human beings that you have food. When Korea or China, when they said you're under quarantine, they brought you food. They brought you 3 squares a day, like clockwork, because they wanted to make sure you didn't come out of your house. So these basic necessities of life, what I call what you need if you're around human beings, this country is poor at, and that drives up our infection rate, and it drives up our mortality rate. And we have to try to fix this before the next pandemic. That's why we lost so many people during HIV/AIDS, right, and why we're losing so many people now.
Yep.
And if I may add to that, Linda, I think that Biden does not have, to my knowledge, a magic wand to fix anything. And the structural inequities that are still perfectly alive and well, and since I can remember, remain in place today. So it's not that COVID and HIV and H1N1 and SARS, they created devastation because they thrive on the land that they land on, right? So if we had these other kinds of structures in place, we would not see the decimation or the devastation or such an uneven distribution of the burden of disease across communities.
Yeah.
Well, let me say this. I'm getting COVID fatigued on this show. Let's talk about some positive things. Now, COVID was unfortunate, but I'll tell you this from my perspective. I've learned so much during this time in terms of having to stay at home. I got to spend more time with my wife and kids. I picked up some new skills and crafts. After I watched all of Netflix, it was nothing left. So I was able to read more and just do some more things. So some positive things did come out of it. So one of the people asked the question, how are you going to celebrate the holidays? How would it affect you? Let me give you an example. On Thanksgiving, I have my father's side of the family, they're East Coast people. I usually don't travel out there to see them that much. We had a Zoom thing, and it was beautiful. I was like, shit, I could do this once a month with y'all. I don't have to hang out with people and go to their house. So even things like if I don't want to talk to you no more, I just click the Zoom off. But bonding with family, learning new things, and just spending time with my wife and kids, man, has been beautiful. So I try to find something positive about this whole COVID. And I've been saving money. I've been spending a lot of money on gas, traveling, clothes, stuff. The only thing I need is toilet paper. That's the only fight when you go to the store trying to get toilet. Right. You got to go early in the morning. So what about you all? What are some positive things that happened to you guys from COVID? Or during this time? Anything?
I'll say two things. One, like you said, Mr. Murray, just spending time with family, seeing my kids every day has been phenomenal. And one thing that I gotta say, and it's surprising and it's not surprising, and it's that, in our health department, I work with a co-lead. I've got a co-lead. And it's kind of incredible, I feel like it's a really rare setup and it really works. And what I really am thankful for is the way that having to go through this with her has really deepened our relationship and our friendship. And I think that's beautiful.
Good. Sounds nice.
Wow.
Yeah. So Rachel Rubin is the only other human whose number I have memorized other than my wife.
Wow. Wow.
I never admit that publicly. I know what you mean, though, but still never admit it publicly, man. Jose Ramon, what about you, brother?
I am a very, very, very gregarious person, so it's been very difficult to be outside of my social spheres and professional spheres. But I'm at home with my husband, and he was working at home before everything started, so he's gained an office mate, and that's been nice, for example, because we have lunch together every day. We step away from the computer and we sit down, even if it's for 5 minutes to open a can of soup and just eat that, but we do that, and we have that time that we never had before in our work lives. I've also been more perhaps intentional in seeking out my family and friends through the WhatsApp group or through the Zoom call, or having Zoom dinner parties with the upstairs neighbors, or being more creative in how I maintain my network, the contact with my loved ones. We don't have anybody in Chicago. My family is in Mexico and in Spain, and Brian's family is in Northwest Washington. So trying to figure out the time zones and the things has always been interesting, but we're making it work, and I feel very close to all my family and my friends.
Well, I think the thing that struck me most about this year, actually, in the midst of COVID, and I think COVID almost acts like a catalyst, and it augments everything, are the massive worldwide protests that occurred this spring and summer over George Floyd and all of the other murders, and the kind of solidarity that we saw inside the country, some of which is not a surprise. I'm not surprised to see other communities of color coming out, but they came out in such large numbers. I was surprised to see so many communities that are predominantly white come out, but also the impact that struggle, the symbolism that it exists around the world. And it's allowed, I think, all of us in the world to have a different kind of discussion. So, for example, on all the campuses, actually in Chicago, certainly at UIC, which of course has many schools, but around the city, people are trying to put in anti-racist curriculum in the medical schools and the nursing schools and the dental schools and health. That's where I usually work in health. The undergraduate students are talking about this. The School of Public Health at the University of Illinois, where the students had been fighting for a course on racism for 8 years. It wasn't until at the beginning of the summer that the school decided, I think after all this protests on the part of the students, yeah, we need to have that. And so they had a course in the fall. So I actually think that this time period that we're in, and I think that George Floyd is just one example of it. I think the election really motivated people to try to address voter suppression and try to turn out the vote and try to take back the White House. I think all of those things stirred people up. And I hope what we remember as we think about a new administration coming in, I don't care who the president is, they only move as far as we, the people, force them to move. And so
Amen.
To me, I'm looking forward to people not suddenly thinking COVID's over, but understanding that this is just another reason why we need to be out in the streets and why we need to be trying to create a world that our grandchildren and great-grandchildren can live in.
Excellent point. So, Jose Ramon, Dr. Kiran, of course we enjoyed you all on. As we get ready to close out, is there anything you would like to share? It could be something from professionally, something personally, just anything, your last 2 cents.
Yeah, just real quick. I go back to the Indian writer Arundhati Roy, who wrote this piece kind of earlier in the pandemic, and she said the pandemic is a portal, right? And so we can pass through it lightly and drop all our baggage, or we can carry it with us, right? It's up to us. And I would much rather see us all the better off and having learned some lessons and having made change on the other side of this than not. And I hope that's the case.
I am very grateful for the opportunity to be here with all of you. And I just want to remind us that we elect individuals to represent us in levels of government. They are our employees, and we need to hold them accountable.
We need to fire more of them.
Damn right.
I agree with that. Doc Murray?
I want to thank all of our listeners for coming on the third Wednesday of the month. And I especially want to thank my colleagues for joining us here tonight and just having a freewheeling, open discussion. I always find it educational. And so I am glad 2020 is about to end. And I look forward to 2021. But I look forward to entering the new year in league with all of you out there as we really have this COVID is not over yet. We're not even halfway through. But more importantly, all the stuff that was there before COVID is still there. So I look forward to continuing to work with colleagues all over the country and world to try to make things better.
And I just want to say also thanks for tuning in. We'll see you guys next year in 2021. We're thinking about adding a phone call aspect so people can call into the show. Mind you, if you call in and you ask something I don't like, I will hang up on you. And the most important thing I want to say, the Bears are on a roll. If we win next week, we'll make the playoffs. If we make the playoffs, we will make it to the NFC Championship. And thanks for tuning in. And thanks, Dre. We'll see you all next year.
Bye-bye. Thanks you. Thank you.
Bye.